السلام عليكم ورحمة الله تعالى وبركاته. بسم الله الرحمن الرحيم. Pulse review. It is basically series of evaluation for the patient, identification of his medical problem, and intervention to correct the medical problem. It is continuation of cycle, identify, then evaluate, then intervene. In the start, we will have to start by initial impression. Initial impression, CBC. C for consciousness. We have to check the patient if he is responsive, if he is conscious or he is not conscious. B for breathing. Breathing, we have to check if he is apneic, if he is not breathing, if he has gasping breathing, irregular or rapid breathing. The other C for the CBC is for color. We have to check if the color pale, pink or mottled color. As I said, initial impression, evaluate. This is the evaluation. CBC, consciousness, breathing and color. Coming to identify. What you are identifying in pulse? You have to identify three things. Either acute life-threatening event or shock or respiratory distress versus respiratory failure. After evaluation, identification, then intervention. The intervention 4 is: first A, activate emergency response system. Second A, apply. Either you will go for applying of oxygen by non-breathing mask or starting CPR if your patient have no pulse. And other A, attach leads. And number 4, attach pulse oximeter. 4 is after finishing the initial impression, we'll come for the primary assessment. Primary assessment, we have it as A, B, C, D, E. A for airway. What we are looking for the airway, what problem will happen in the airway? We have to identify first, as we said, we have to check if it is open, if the airway patent, no secretion, no problem with it. Is it maintainable or no? If it is open and patent, we have to give oxygen by non-breathing mask if the patient is breathing. If the patient not breathing or have shallow breath, immediately we have to start positive pressure ventilation and bagging. If the airway is maintainable, we have to open it by head tilt, chin lift, or jaw thrust if suspected cervical spine injury. But if mentioned the airway is not maintainable, this means we have to go for advanced airway intubation by putting endotracheal tube, LMA or tracheostomy tube. After the airway, coming for breathing, parameters we are evaluating for breathing. First, respiratory rate. Second, work of breathing, respiratory effort, and chin rise, chest rise. Number 3, air entry. Number 4, oxygen saturation. And according to this, from this breathing, the rates, the effort, the saturation, and the air entry, we can identify the respiratory problems if it is respiratory scenario. Actually, we have 4 respiratory scenarios. Either upper airway obstruction or lower airway obstruction, lung tissue disease. Number 4, disordered control of breathing. When you evaluate for the breathing, all of them or most of them you'll find there is rapid breathing. Maybe except for disordered control of breathing, he may tell you there is shallow breathing. And he will tell there is decreased respiratory rate and effort. But the other scenarios, upper airway, lower airway, lung tissue disease, all of them there is increase in respiratory effort, there increase in respiratory rate. All of them you have decreased oxygen saturation. Okay? In the upper airway obstruction, he will mention for you there is stridor. For lower airway obstruction, you can find there is wheezes. In the lung tissue disease, you will find that he will mention there is grunting and crepitation. Okay, so what is the intervention? Intervention by giving, as we said, if the patient is breathing, you have to give 100% humidified oxygen. If he mentions shallow breathing or diminished breathing or apneic, like disordered control of breathing, you have to mention you will start ambobagging, positive pressure ventilation. If mentioned to you stridor, also you have to give epinephrine IM and give nebulizer of epinephrine and dexamethasone IV. If there is a wheeze, this means lower airway obstruction, you will give 100% of modified oxygen and salbutamol nebulizer. If it is lung tissue disease, he mentioned to you crepitation or grunting, at this point you have to give 100% oxygen plus IV antibiotic. For disordered control of breathing, usually you will give, as we said, positive pressure ventilation, and also you have to ask about the cause. And if it is there is a reversal agent, you have to give the antidote or the reversal agent. After you finish breathing, as we said, first for primary assessment, airway, you ask about patency, maintainable, not maintainable, any secretions or not. Then coming for breathing, you ask about the respiratory rate, the saturation, respiratory effort, and if any added sound. After that, you come for circulation. In circulation, also you have specific things you have to ask about it. These things or these parameters are heart rate. You have to ask about the heart rate, pulse, central and peripheral pulses. You have to ask about capillary refill time. Then you have to ask about blood pressure. And blood pressure should be more than the 5th percentile for age. This is a normal. And you have to ask about peripheral temperature and skin color. For blood pressure, what is the normal blood pressure, or what is the 5th percentile for blood pressure? Because if the patient have blood pressure below the 5th percentile, we have to consider him as hypotensive. If the patient is age above 10 years old, his systolic blood pressure is supposed to be more than 90. If his age below 1 year, his systolic blood pressure is supposed to be below 70. And if the age between 1 to 10 years, his systolic blood pressure is supposed to be above age times 2 plus 70. Like if he is 5 years old, so the age is 5, 5 times 2 it will be 10, plus 70, 10 plus 70 it will be 80. This for the blood pressure. For capillary refill time, what's the normal capillary refill time? 2 to 3 seconds. Okay. For circulation, why you have to assess the circulation? You have to concentrate always during circulation about the blood pressure, as we said, because if below 5th percentile, it will be considered a hypotensive. If the capillary refill time is prolonged more than 3 seconds, and peripheral and central pulses are weak, and cold extremities, if blood pressure normal, it will be compensated shock. If blood pressure is low, it will be considered as hypotensive shock. So from circulation, I can identify if the patient is in shock or he is not in shock. If he's and if he's in shock, what type of shock? We have 2 types of shock, either compensated shock or hypotensive shock. And also, after I identify the patient have hypotensive or compensated shock, I can differentiate more for shock because I have 4 types of this shock. Either it is hypovolemic shock or obstructive shock, distributive shock, or cardiogenic shock. We have usually 4 scenarios for shock in pulse. This 4th scenario of shock is hypovolemic shock, obstructive shock, distributive shock, and cardiogenic shock. And any one of them can be compensated shock or hypovolemic shock according to blood pressure. After this one, if you identify the patient have shock, you have to intervene directly. Whenever you find problem, you have to make intervention to correct this medical problem. What you have to give? You have to give crystalloid, normal saline, or ringer lactate, 20 ml per kg, up to 3 times, each in 10 to 20 minutes. You give it as bolus. And you have to be careful, looking for signs of fluid overload. Every time when you are repeating the normal saline, you have to auscultate the chest for any crepitation. Look for any signs of fluid overload. If you have patient with hypotensive shock, you have to consider starting inotropes or vasopressor agent for fluid refractory shock. You start your IV fluid, then you will complete your primary assessment. Ask about, as we said, A, B, C, D. D for disability. Disability, you will look for his classical coma scale, if he is conscious or no. Look for his pupils, reactive or equal or no. Check blood glucose. After disability, coming for exposure. Exposure, temperature, check his temperature, any bleeding or any bruising or no. When you did this, when you evaluate your patient up to the end, then you identify patient have like he's in shock, compensated or hypotensive shock, then your intervention. As we said, it could be a specific intervention, but there is one intervention in all of them. After primary assessment, you have to put vascular access and you have to check the rhythm, if it is regular rhythm or no. After that, we are going to give assessment for secondary assessment. What mean by secondary assessment? Secondary assessment means we are going to give focused history and focused examination and checking for vital. Secondary assessment. Secondary assessment evaluation وبعدها يجي identify, then intervention. For evaluation, sample history. Sample S for sign and symptoms. Then A for allergy, if the patient known to have allergy from anything. M for medication. B for past medical history. And L for the last meal. Well, E, event. After that will come the physical examination, starting for repeating vital signs. Heart rate, respiratory rate, oxygen saturation, blood pressure. It have to be checked again, vital signs. Then head to toe examination. Head, eyes, head, then eyes, then ears, then nose, throat, neck. Examination for the heart, especially if there is any galvanizing or no. Then examination for the chest. Examination for the chest, look for bilateral good air entry, if there is any crepitation or no, if the air entry was equal bilaterally, and if any transmitted sound like crepitation or wheezes. Then coming abdominal examination and pelvis, looking mainly for if there is any hepatomegaly, because hepatomegaly will come if there is any sign of heart failure. After that, extremities, then back and neurological examination. After you finish from the evaluation and secondary assessment, then you will identify the case according to the primary assessment and secondary assessment. If it is shock, if it is compensated shock, and if it is hypotensive shock, and what is the name of the shock. Is it obstructive? Is it hypovolemic? Is it distributive shock? Or any other type of shock? Then intervention will become according to the case you identify, according to the medical problem you identify, either to give normal saline, as we said before, 20 ml per kg for 3 times, or considering inotropes, or if it is something like upper airway obstruction, you will consider giving epinephrine. I want to give one scenario for pediatric pulse. One scenario about shock. The scenario, while you are working in the emergency department or in the ward, you have a child who's ventilated, unintubated, in the emergency room, and he was sedated, and suddenly the nurse came shouting. She is telling the patient he looks unwell and he's desaturating. What you are going to do? First, you will go by initial impression. Evaluate. Consciousness, sedated, becoming increasingly agitated. Then you have to ask about breathing. As we said before, CBC, consciousness, breathing. Breathing, he's intubated with poor chest rise and poor chest movement. Color, he have pale mucous membrane. He have pale mucous membrane. Identify, at this point, you will identify patient with respiratory failure. Also, you can say it is acute life-threatening event. Intervention, as we said before, 4Rs, activate emergency response system. Then you will disconnect from his ventilator and you provide him with oxygen by ambu-bagging or positive pressure ventilation. You will begin manual ventilation. And you will go for the primary assessment. In the primary assessment, you will start by the airway. If it is open, clear, if there is any secretion, if it is maintainable or not maintainable. If mentioned there is secretion, you will tell I will suction. If not opened, you will tell head, tail, chin, lift to open the airway. If suspected cervical injury, you will use the jaw thrust. If not maintainable, you will consider advanced airway, like intubation or LMA or tracheostomy. Then coming for breathing. He is ventilated at 24 per minute, but there is asymmetrical chest rise and the breath sound was decreased on the right side. And you need more pressure to move the chest. Saturation is dropping, now reaching up to 60 and going down. So, once you hear this information, immediately the student have to attempt to evaluate by using Doppler monomeric D for displacement. You will check the depth of insertion, if it is changed or no. If the depth was not changed, so unlikely to have displacement. Obstruction. When you check suction, you will suction. If there is no secretion and there is adequate breath sound on the left, so the tube obstruction is unlikely. And you can do the suctioning. Pneumothorax. B for pneumothorax. Dop, B for pneumothorax. Pneumothorax is consistent with this one. Why? Because the movement of the right side of the chest not moving properly and the breath sound is decreased in the right side. After this one, we have DOP, D-O-B-E. E for equipment. Equipment failure ruled out during manual ventilation. Equipment failure, it is ruled out because you disconnect the ventilator and you are doing manual ventilation. After this one, now you have something serious. You cannot continue for circulation. Immediately at this point, you have to identify you have patient with respiratory failure. Either you will go for needle chest decompression in the second intercostal space, mid-clavicular line, or if you want to complete the circulation to see the situation of the heart, but you have to do it, but don't finish up to the end. So for the circulation, you have to ask about the heart rate. If you mentioned it's 130, peripheral pulse is weak, central pulse is present, capillary refill time around 5 seconds, blood pressure 70/50, and he is, as we said, 3 years old. So 3 years old, immediately I will consider blood pressure 3 times the age plus 70. 3 times 2, 6 plus 70, 76. I will identify at this point respiratory failure and blood pressure is low, so we have hypovolemic shock, and probably I have pneumothorax. Pneumothorax. Intervention at this point, my intervention, I will analyze cardiac rhythm. Already, if you did not put the needle decompression, you have to put it at this point, and you have to arrange for chest tube. And after this, you will consider giving normal saline to reverse this shock. And most likely the patient will improve if you make needle decompression. After you make the needle decompression, you started fluid for the patient. You start the secondary assessment. Sample history, sign and symptoms, recent history of pneumonia. Patient came desaturating 2 years and he was intubated. Allergy, he is not known to have allergy medication. He have started first dose of antibiotic for pneumonia. Past medical history, he have pneumonia and he have respiratory failure 2 years before this event. Last meal, he did not take anything since last night. Event, sudden deterioration in the ER after intubation and he improved. Suddenly again he deteriorated. After that, I will go for physical examination, repeat the vital signs, check it from the start, saturation, 100% now after you did needle decompression, heart rate 160, respiratory rate 20 per minute, and blood pressure now 80/50. But if you did not do needle thoracostomy, the saturation will drop more and more and blood pressure will decrease. Head, eye, ears, nose, and thoracic and chest and neck examination, heart examination, abdomen and pelvic examination, extremities, back, and neurological exam. Then, after the secondary assessment, you will identify patient with respiratory failure, with hypovolemic shock, deteriorated. If patient not improve, if it's compensated, it will become hypovolemic shock. And at this point, after secondary assessment, you have to tell the exact type of the shock. Like this, it is obstructive shock, and probably it is pneumothorax. Intervention, after you put the needle decompression, you will prepare for chest tube. You consider fluid boluses, second bolus, if the blood pressure or the extremities is still not warm and the capillary fill time is still delayed. As we said, we can give IV fluid three doses every 10 to 15 minutes, ringer lactate or normal saline, and we can consider inotropes for refractory shock or vasopressors. Other scenario, I will give it for patient who is 12 years old and he is not eating and he have vomiting and he have diarrhea for the last 7 days. Patient came and he was admitted in the ward. And the mother is calling you, he's feeling her baby is not responsive for her like before. So evaluate the patient. First, you will go for initial impression. Evaluate consciousness, breathing, and color. As we said, CBC, consciousness, breathing, and color. Consciousness is lethargic. Breathing, there is increase in the rate, no increase in effort. Color, he have pale nail beds and mucous membrane. You look here. Increase rate, no increase in effort. This means it is not respiratory distress. Pale color, most likely it is going with shock. So when you identify, it is probably shock. Intervention, what you are doing for is activate emergency response system, apply oxygen, humidified oxygen 100% by non-bracing mask, attach pads and lead and turn on the monitor. Apply pulse oximeter. After this, you go for primary assessment. A, B, C, D, E. A for airway, it is clear, patent, maintainable. Breathing, looking for respiratory rate, respiratory effort, saturation, and chest exam. Going for circulation, heart rate, 120, peripheral pulse is weak, central pulse is present, capillary fill time 3 to 4 seconds, prolonged. Blood pressure 82/58. You see, he's 12 years old. Any patient above 10 years His systolic blood pressure should be above 90. Any blood pressure below 90 for patient above 10 years old means he is hypotensive. Disability, he is lethargic and he is not communicating. Exposure, he have temperature 37 and his blood glucose is 50. Identify at this point hypotensive shock. Because blood pressure is low, this means it is hypotensive shock. So, what is the intervention? Your intervention, you will obtain vascular access. You have a team. Once your team arrived, immediately you have to divide your team. You will be the team leader. You have to stand at the end of the bed and you ask, when for the vascular access, you put cannula, I need IV access, take blood sample for blood gas, CBC, chemistry, and whatever you need, if you need culture or others. And you advise him also to give bolus of normal saline, 20 ml per kg over 10 minutes. Other one, assign him, you will be responsible from the monitor, check the rhythm and inform me. When it is ready, you check it, it is sinus tachycardia. Other one, he will be your recorder. And you need other one to take care about the airway, will apply the oxygen. Other one, he will be standby for chest compression in case it is needed. After you finish this one, you go for your secondary assessment. As we said, sample history, then physical examination, starting by vital signs and head-to-toe exam. After the secondary assessment, you evaluate it, you go for identify. You mentioned before hypotensive shock. At this point, you have to mention what type of shock. And from the sample history, he have vomiting and diarrhea. So it is hypotensive, hypovolemic shock. You have to repeat the IV fluid again, or 3 times. You can repeat it and you can consider inotropes. After that, you can send the diagnostic test that you need. This for hypovolemic shock. Now we have other baby who is no case of leukemia. This patient, he's 13 years old and he is coming, he's in chemotherapy and he's febrile for the last 3 days. And they brought him in the ER. He is very sick. And it is you are the one who is examining him. So, what is your evaluation? First, as we said, initial impression. Evaluate, identify, intervene. Evaluation for consciousness, breathing, and color. CBC. C, consciousness. B, breathing. C, color. CBC. Consciousness, breathing, and color. Consciousness, he is lethargic. He is not interactive. Breathing, there is increase in rate, but no distress. Color, he has pink color. You identify, you see usually with all the shock you have color pale, except one shock. You will have pink color. So what is your intervention? What you will intervene? You activate emergency response system and give oxygen, attach bats and lead and turn on the monitor and apply pulse oximeter. Then you go for your primary assessment, A, B, C, D, E, as we said. Airway, clear, maintainable, and patent. Breathing is respiratory rate 15, assisted. No increase in effort. Lungs, clear, saturation 95%. Circulation, heart rate 125. Peripheral pulse is strong. Central pulse is bounding. Capillary fill, brisk blood pressure 80/40. You see his age is 13 years, we said, and it is 80, means below 90, which means it is hypotension. Disability is lethargic and not interactive. Exposure, temperature 39. my identification at this point, my identification will be hypotensive shock. Intervention, verify the examination of the patient by checking his cardiac rhythm, sinus tachycardia. Administer immediately fluid, 20 ml per kg, 3% normal saline or ringer lactate. We will give fluid bolus of 20 ml per kg of isotonic crystalloid like normal saline or ringer lactate. Then coming for secondary assessment, as we said before, sample history. A sample, then physical examination, starting vital signs, then head-to-toe exam. Then you identify hypotensive shock. You mentioned before, you have to decide what type of hypotensive shock. At this point, patient febrile, patient sick. This is distributive shock or septic shock. Intervention, repeat the bolus of normal saline. Then you have to consider inotropes and you have to send the blood test for investigation. This one, now what we said, distributive shock, and we talk about the obstructive shock. We talk also about hypovolemic shock, and we have the last type of shock, which is baby came 3 months old. He have runny nose, he have mild cough and runny nose, and the mother noticing since morning he have decrease in oral intake. He was admitted in pediatric ward, and the mother calling you, she is not feeling her baby well. So your initial impression, evaluation, first you have to check his CBC, consciousness, his lethargic, breathing, increased rate and effort. Color, he have pale skin. What you identify here, because pale, possible shock. Because increased rate and effort also, he have respiratory distress. Your intervention, immediately activate emergency response system, administer high flow oxygen, attach leads and pads, and apply pulse oximeter. Then coming for primary assessment, start by evaluation, airway, clear, open, maintainable, breathing rate about 55, this means he's tachypneic, significant subcostal intercostal retraction, mild nasal flaring, head bobbing, and head bobbing, this is one of the signs of severe respiratory distress. Saturation 93% on room air, and 97% when you applied 100% oxygen. Circulation, heart rate 180 to 200. Peripheral pulses are weak, central pulses are fair. Capillary refill time about 4 seconds. As we said, capillary refill time supposed to be 2 to 3 seconds. If it is above, this means it is delayed. Cool and slightly dusky hand and feet. His blood pressure 74 by 54. Is it normal? Yes, because he's below 1 year, and the blood pressure below 1 year is supposed to be systolic accepted is up to 70. Disability, he's lethargic, pupils normal, exposure temperature 37, no rashes, and his glucose is normal. What is your identification? You have to identify at this point. Respiratory distress, yes, right, and compensated shock. Why compensated shock? Why he's in shock? Because capillary refill time prolonged 4 seconds, and peripheral pulses are weak. Why you mention compensated and not hypotensive? Because blood pressure is normal, so it is compensated shock. Intervention, analysis for the cardiac rhythm, and assess the response to oxygen. Coming after that, secondary assessment, as we said before, sample history and physical exam. We have to take the sample history as signs and symptoms, allergy, medication, past medical, last meal, and event. Physical examination, vital signs, Repeat vital signs after the administration of oxygen. Heart rate 180, respiratory rate 55, still saturation 100, blood pressure 74/50, normal. Head examination, heart, rapid rate, galoprism. Whenever you find in the scenario galoprism, means this something in the heart, no normal. Crackles at lung base. You have now positive galoprism and crackles at the chest. Abdomen not tender and extremities cool. And in the abdominal examination, he have palpable liver. He have hepatomegaly around 4 cm below right costal margin. Extremities normal, back normal, neurological exam normal. So what you identify at this point? Compensated cardiogenic shock. Why cardiogenic shock? Because you have galoprism in the heart, you have crepitation in the chest, you have hepatomegaly. All these are signs of heart failure. What is the signs of heart failure in this patient? Tachycardic, he is tachypneic, he have galoprism, there is crepitation in the chest, there is hepatomegaly. So this patient have compensated cardiogenic shock. You have to take care for fluid. You put the vascular axis. When you give fluid bolus, you have to give 5 to 10 ml per kg of isotonic crystalloid carefully over 20 minutes. And you have to consider inotropes earlier at this. And after that, you have to consult the subspecialty needed and transfer your patient to the ICU.